Thank you, Mark. Thank you, everybody. We go on our journey on sexuality, and we start from what we said before, that sexual dysfunction are very common in women of every age. But I will show you that, of course, this at menopause is much more important. You see that we have many symptoms out there: lack of sexual interest, unable to achieve orgasm, pain during sex, and sex that is not pleasurable. And we know from these early studies that there is a strong impact of female sexual dysfunction on quality of life and well-being. It's an impact that is even stronger than the impact that erectile dysfunction has on men. Low physical satisfaction, you see, 4 times more likely to have it. Low emotional satisfaction, 3.5, and low general happiness, 2.6. So it's not a trivial issue for our patient. And indeed, the impact on quality of life in sexual medicine is measured by considering the distress. What is the distress? Is the real impact that has on the woman and on the relationship. And the distress, so the impact on quality of life, is an essential part of a diagnosis of female sexual dysfunction. You see that with the new classification, we have different areas of disorder: arousal, desire, orgasm, and sexual pain, but distress should be always there, and it should be there the maximum of time. At least 6 months, the woman feels this distress into the situation. We have scales to measure sexual function and sexual distress. The scale that we more used in clinical practice, and many of the results I will show you, they rely on this scale, is the female sexual function index. You see we have a total score between 2 and 36, a cutoff of 26.5, and this scale, they measure all the different domains of sexual response: desire, arousal, lubrication, orgasm, satisfaction, and pain. But the scale that is most relevant when we want to measure quality of life is the female sexual distress scale revised. You see a list of questions, and one that is very important, that is the last question, in which we measure if women, they are bothered not only by the symptom, the one they are physically, but most importantly, the symptom, the mental symptom of the sexual dysfunction, that is sexual desire. Because if you bother very much on sexual desire, sometimes when you deal in menopause practice, you really need to reverse this component, and not the component we know so well is so important for menopausal women, that is genitourinary syndrome of menopause. I will show you in a minute. So to try to avoid this problem of overlapping of disorder for menopause is very essential. We know that when we measure the impact on quality of life, the symptoms are there, but they are not distressing for the woman, so they are not really clinical entities sometimes, and just women, they cope with the symptom. So when we consider all the symptoms in a woman's life, we may say that 1 out of 10 women suffer from low desire, 1 out of 20 suffer from low arousal, and more or less 1 out of 20 suffer from orgasmic dysfunction. In any case, in our office, 1 out of 10 women, they really need our help. When we deal with menopause, the picture is complicated by the fact that age is affecting the distress, because women, they cope with menopause. They enter menopause, they feel that their couple is changing, and so they report the symptoms. So they will tell to you, I have sexual pain, I have low desire, but they say, okay, I'm fine, I can cope with that, and I don't want to do nothing. So this is crucial in our practice, to try to find the right motivation for women, and what we have to reverse. We have to reverse the sexual dysfunction, or we have to reverse the underlying condition we have in menopause, and the most important one, as you know for sure, is genitourinary syndrome of menopause. Indeed, you see that when we put together having a symptom and having distress, there is a peak around the time of menopause. So menopause is significantly distress for women in this context. Women, they perceive, when they have any kind of sexual dysfunction with menopause, with natural, but even more with surgical menopause, because we know that in surgical menopause we have a major challenge. First of all, sometimes it comes early in a woman's life, maybe it's the result of an underlying medical condition, let's say even a benign gynecological condition, but even a malignant one, or a condition, let's think about, like endometriosis, that is giving by itself some kind of sexual pain. But also it's very important to remember that when you have surgical menopause, you shut down completely the ovarian function, and so you shut down the hormonal milieu that is there. But in any case, the most important issue is really that when women enter menopause and they have a sexual dysfunction, they perceive, you see, that their general health is strongly impaired. And you see, women, they have less sexual dysfunction, they feel very good. The one they have more sexual dysfunction, they feel that their health is poor or is just fair. And so this is very important when we consider menopausal women, to try to figure out all the different medical conditions they can be there, and they can play a role, a part, hormone. We know the hormonal issue. We know less about some kind of comorbidity. Which one are the most important comorbidity apart endocrine condition? Medical condition, general medical condition. And when we look at the correlate of sexual problem associated with distress, and we focus our attention especially in menopausal women, you see that the one they are most significantly, they are mood disturbances, so anxiety and depression, and urinary incontinence. So the mechanical, the physical part, the urogenital system on one hand, and the brain, so mood, anxiety, depression, and so on. And you may observe that some conditions, they are so relevant for male sexual dysfunction, such as, for example, hypertension, diabetes, or heart disease, either directly because the condition impair the neurovascular function, but also indirectly because you have a lot of drugs that may interact with the sexual response. At least in this big study, there was no significant impact. So for us, in the real life in medicine, it's important, and in the menopause field, it's really important to rule out for urinary incontinence and mood disturbances when we study this issue. And that sexual well-being is so crucial at menopause. Our society, International Menopause Society, the one I'm serving on the board, devoted the last white paper last year. You see, because for us, it's really essential to break the ice with our patient. Everyday practice, we really need to be proactive, because we discover over the year that women, they don't talk so much, doctors, they don't ask, because maybe they don't know exactly how to handle the complex issue of sexual function and well-being, but this is essential for quality of life of women. And the first thing we should learn is really to rule out the most common and the most significant condition that is associated with hypoactive sexual desire disorder in these women, that is GSM, vulvovaginal atrophy. And when we are in the menopause field and we deal with this patient, we will discover that 40 to 50% of the women that enter our office, they have some kind of symptoms. But if we do not assess the distress, as I told you at the beginning, we are not able to motivate them to be assessed and, most importantly, to be treated. So we really need to follow this track to try to understand what's going on. I always have to remind to everybody that when we deal with sexuality, we deal with a multidimensional issue. So even a condition that is so biologically driven, such as vulvovaginal atrophy and GSM, we know very well that the vagina become a little vagina instead of an healthy big vagina like we are during the fertile age. You recognize there the loss of vaginal elasticity, vaginal dryness, a lot of signal of involution of the organs. They are strongly related to hormonal changes, aging per se, of course, lifestyle factors, sexual activity, comorbidities, as I said. But keep in mind that having an unhealthy vagina, having GSM, means also other things for women. A lack of self-esteem, problem with body image, depends also how the woman feel the role in the society at the time of menopause. The vagina, the aging vagina, is a marker of general aging for women. And also we are in a multicultural environment, so the attitudes toward menopause and aging play a role in the way women, they say, okay, I have the symptom, but they underreport and they don't want to be treated because they just accept that. When we try to understand the impact of this cluster of symptoms associated with genitourinary syndrome of menopause, you know for sure vaginal dryness and dyspareunia are the essential symptoms we have in every scale in our menopause field. You see that there is a direct impact on really the perception of sexuality and the relationship. You see, this is a study we conducted in Europe, so the REVIVE study, Italy, Spain, UK, and Germany. We are at the European Society, so I prefer to share this data. And you see that the most important aspects of quality of life and well-being, it's really sexual satisfaction is impaired, sexual spontaneity, intimacy. So it's something that goes into the couple and relation with the partner. But we have also other dimensions. They are more part of general quality of life, such as the way you sleep, the way you practice, for example, exercise, the way you travel. So when you don't feel good in your genital, when you feel dry in your vagina, you don't have only something happening to your sex life, but also in general to your feeling of well-being. Why is so important to consider GSM in our routinary practice if we want to prevent sexual dysfunction? Because it's important you remember these symptoms are epidemic in a menopause clinic. If we move from the general population, in which we can find in survey 40-50%, as I said, if we move to our clinic, and this is a study I did with my dear friend Santiago Palacios, comparing Italy and Spain, always because we want to try to find a similar population. We are a Latin country, but with different cultural and environment anyway, to try to understand what's going on in terms of sexual function and behavior. And you see that these symptoms are more or less affecting the majority of women, more or less 90%. But symptoms are also extremely subjective. This is a very important point you should keep in mind. There are women, they report having the symptom, but they are not having a confirmed genitourinary syndrome of menopause. You know that you can diagnose this condition by eyes, you can see that the vagina is pale, you can measure the pH, you can do whatever to try to say, okay, this woman has the condition, the medical condition objective. What is important is the subjectivity, because of course women, they come, they have this request. Even though you don't see with your eyes, they have the symptom. This is a very important information. And you see that symptoms are very diverse. The most common one are the vaginal dryness and pain during intercourse, but you see that we have also pain during exercise, bleeding during and after intercourse. This is a very important symptoms because we do a lot of investigation in these women, sometimes maybe hysteroscopy or colposcopy, other stuff, and it's just vaginal dryness and GSM. This condition has a strong impact on quality of life. We measure the impact on quality of life with general scale for quality of life, such we use for osteoarthritis or other general condition, the Eurocall EQ5DL, and we use a scale that has been validated in women with vulvovaginal atrophy in the menopause that is named DIVA. DIVA is a scale that considers the impact that all the symptoms have in different dimensions of women's life. And you see that overall, women reporting at least a symptom of GSM or VVA, as you want to call, they have a significant impairment of quality of life at multiple levels. In particular, the one, of course, they have both the subjective symptom and the objective symptoms. Symptoms are not all the same in sexual medicine when we deal with menopausal women. We have to consider that we have different clusters of symptoms. We have symptoms that are more vaginal, there are symptoms that are more vulvar, there are symptoms that have more in the urinary system. Of course, they can overlap, or sometimes they do not overlap. And why is essential to understand this? Because maybe one treatment cannot fix everything. And also, this is a very important point to keep in mind. If you have more vaginal symptoms, maybe you will be more responsive, let's say, to estrogen treatment, whereas if you have more vulvar symptom and the urogenital sinus is so sensitive to androgen, you should play with a different combination of treatment. And so it's important to make a correct diagnosis. When we consider women with confirmed VVA, however, the impact on sexuality is even stronger, is very much strong in every dimension: desire, arousal, lubrication, orgasm, satisfaction, and pain. So when you have all the symptoms and they are out there, they speak aloud and they say hello to you because the vagina is really, really impaired. Sexuality, of course, is destroyed at every level. And this is the reason why we really need to be proactive with our patient, because otherwise they will develop also other disturbances that maybe are more difficult to be fixed because they come into the psychology, into the relationship. And when we look at the impact of the different cluster of symptoms, it's interesting, you observe that they are all important. Vaginal, they are important, vulva are important, and urinary symptoms are important. But you see that the symptoms, when you have together the urinary symptom and the vulvar symptom, you have a significantly stronger impact on the sexual dimension in comparison to other dimensions of quality of life: self-concept, daily activity, and emotional well-being. So the summation of all the symptoms is really relevant. And why is important to make this point for practice? Because in another analysis we did of the same study, EVE's study that was conducted in Europe, with Nick Panay, what we found? We found that women, they come to our clinic and they are already treated with some kind of hormones. I don't go into the details. Any kind of treatment we use to reverse GSM at the present moment. Also, hormone replacement therapy, okay, systemically. What we observe that these women, they were the one having the most severe symptom. So there is something weird out there. How is possible that the treatment that is reversing that condition and these women, they are suffering more? Why? Because there is a delay in giving the treatment. So at the present moment in Europe, in our hands, in the EVE's study, what we were able to demonstrate is that treated women, they are the one reporting more symptoms, and they are the one as well, they report stronger pain and discomfort significantly when we consider the general scale of quality of life, and even when we consider the DIVA. So the DIVA measuring daily activity, emotional well-being, sexual function, sex, self-concept, and body image. You see, they are extremely significant. The only scale is not significant is the impact on daily activity. So, my dear friends, my conclusion is that we have to face this issue and we have to follow a frame of mind when we want to improve sex and quality of life in the menopause office. We really need to facilitate the discussion. We really need to recognize the condition. We have to be sensible. It's not a trivial issue. Maybe it's important osteoporosis, it's important the cardiovascular system, but it's even more important sexual function and quality of life. We have to educate women about the risk factors. We know, for example, that smoking is a risk factor, cesarean section, elective delivery is a risk factor. We know a lot from the literature. We can put on stage and we can counsel our patient. We really need to understand which are the need and the expectation of our patients. So we really need to measure the distress, because if a woman, she is alone, if a woman has a partner with some kind of medical condition, maybe she does not feel the motivation to be treated, but the condition will be there and will affect her later on in her life. We'll need to consider, of course, all the different options we are out there, because they can serve different purposes. And we have really, we need to have the objective to effectively treat VVA, but we probably have to start early to obtain a better response to treatment. Otherwise, women, they will come back, they will have always the symptoms, and when they will be treated, it will be too late, and they will suffer very much. And with this, I invite you in Melbourne